Hello and welcome to this episode of GLI Live. This is the first episode that we have on our new platforms, StreamYard, and we are able to simulcast across social media platforms. So wherever you are viewing us, however you're viewing us on Facebook or Twitter or Instagram or on our website or YouTube or things that I don't know about because I'm over 24. I welcome you and hope you enjoy this episode. My name is Donna Cryer. I am the founder and CEO of the Global Liver Institute. I am also a liver patient, and I have with me today two guests who are going to help me keep launching GLI's Day in pediatric and rare liver diseases. Did you even know that there were pediatric liver diseases, that children can get liver disease? Did you know that there are more than 100 different liver diseases? For those of you, whether you did or you didn't, you will know more about at least one autoimmune hepatitis by the end of this time together. So our GLI Lives started as part of our COVID response to patients with autoimmune diseases, liver transplants, cancer, and we know that it has grown to mean so much to so many more as we continue to bring expertise and comfort and connection throughout this time. So my guests today are Dr. Craig Lammert. He is we've had hepatologists on the show today, but he is extra special. He has studied fantastic things like hepatogenomics and autoimmune diseases. And so we are excited to welcome Dr. Craig Lammert.
Thanks for having me, Donna.
Thank you. And then because the patient voice is paramount on GLI Live, and we hopefully soon everywhere, Katie Misz is with us. She is an autoimmune hepatitis patient, and she is going to share her experiences with us and also her thoughts as we look at gaps and challenges and opportunities in the autoimmune hepatitis space and in the pediatric and rare disease space. I would be remiss before, before we got into the midst of this today, if I didn't recognize the recent loss. I think even my light recognized the loss of the founder of the PVCers, Lenny Moore. And also just this weekend, as we were all in the liver meeting, we heard about that, and it hits us all so hard, and we extend our condolences to that organization and our support as a member of the rare liver diseases community to do whatever we can to make sure that that organization and that work and that outreach to PVC patients continues. And then we've also recently seen the loss of PSC patient and transplant recipient Jamie Redford, son of the actor Robert Redford, and an artist and activist in his own right, a friend. And so for so many people who don't know about rare liver diseases, who don't appreciate, because so many of us, many of us walk around looking pretty healthy, and we'll address that in today's episode. They don't realize how serious pediatric and rare liver diseases are, how deadly they can be. And so, under the large umbrellas of rare diseases, of which there are 30 million rare disease patients, so actually a large group, or under the auspices of liver patients, of which there are 500 million around the group, so very large group. How do we get attention for the pediatric and rare liver diseases? So the launch of our GLI Pediatric and Rare Council today is part of that effort to shine that spotlight on the pediatric and rare liver diseases. So with that overlong intro and setup, I want to start with Dr. Lammert, just telling us all a little bit about what is autoimmune hepatitis, because we assume most people don't know.
Yeah, thanks, Donna. And I just want to say thank you to GLI for focusing that spotlight on our disease, but all autoimmune liver diseases for that matter, as all three of the ones that we'll talk about, maybe touch on intermittently today, PBC or primary biliary cholangitis, PSC or primary sclerosing cholangitis, and autoimmune hepatitis are all rare in their own right. And they're all very heterogeneous. They all look very different, but they target different tissues of the liver, from the liver cells themselves to bile ducts. The disease autoimmune hepatitis is the one that actually will focus more on the hepatocytes. And really the way to understand this is the immune system attacking a liver tissue that expects that patient's liver is foreign. We don't really understand why this happens. And I think that's one of the most important pieces in trying to understand pathogenesis or disease-causing contributions to disease. We think it's probably related to genetics, but we also have a real belief that the environment is incredibly important in this. And I think that is a big area of research, and also how these genes and environment interact to cause autoimmune liver diseases. Ultimately, the good news is, at least for autoimmune hepatitis patients, there is therapy. But don't be surprised when you meet an AIH patient that says maybe sometimes the therapy is worse than the disease itself. As we know, the medications come along with many side effects. These also include prednisone, which I think many of our members would realize prednisone comes with its own bag of issues as well. So either way, with this liver inflammation, it can cause fibrosis and result in a need for liver transplantation. But some really important unmet needs are apparent in this disease, which we can talk further about, but to highlight a few of them. One is how heterogeneous this disease is. It affects everyone, males and females, despite being a female predominant disease. Many patients will have many what we call extrahepatic symptoms, everything from fatigue to poor sleep to mental illness of depression and anxiety. And beyond that, we also don't have any individualized medical care. We treat this disease much like a nail, and me as a prescribing doctor as a hammer. So ultimately, we have a lot to learn as we move forward with this disease, and all autoimmune liver diseases for that matter.
Wow. Thank you for that. That's an important start. We're going to unpack a lot. So Katie, make it real for us. Tell us what it's like living with an autoimmune liver disease.
Yeah, thanks, Donna, for having me. So I came back from a semester abroad in college, and I was 19, so I guess just on the cusp of that transition from pediatric care to managing my own health care. And I came back and I thought I had a parasite. Just wasn't feeling super great. So I went to the student health clinic at my university, and they took blood work and found my liver enzymes were above 1,000. And my school immediately freaked out and sent me home, thinking that I had contagious hepatitis and that I was a danger to the student body, which is something that is often misunderstood with autoimmune hepatitis, because it's my immune system and not something other people need to be afraid of me. So at first, I really wavered between resisting the diagnosis and the illness, and accepting this new reality that I had a lifelong chronic disease and would need to manage it. I did not want this thing to hold me back. And also realized that I sometimes didn't feel good. And I am I know some AIH patients, autoimmune hepatitis, it's often referred to as AIH. Some AIH patients go into remission. I was not one of those. So I have needed medication and will continue. So living with chronic illness and chronic pain is exhausting. I don't think I could have realized the emotional drain that would cause. I guess, yeah, I think for my particular story, I would highlight that as one really important aspect. Being a young adult, when I was diagnosed definitely plays into that. Being a female plays into that. When I had acute symptoms or times where I needed care, I felt like I was yelling into the void, saying, "Hey, I need help over here," and it kind of got passed around between specialists or PCPs. And so one particular story, I got the stomach flu, and those of you on immunosuppressants and on prednisone know you get it extra bad, and it didn't go away. So I went to the emergency room, got some fluids, and then the nausea just did not go away. So I was nauseous 24/7 after this. Again, was one of those times I sought doctor after doctor. Eventually had a secondary diagnosis of adrenal insufficiency, had some changes in meds, changed my diet, lost a ton of weight, went down a pretty dark hole of just feeling awful all the time. So I had a couple doctors tell me during that it was all in my head. And if you are a medical provider listening in, just don't ever say that. Like, it does not help anybody. That is not a good way to introduce deeper conversations of mental health or to care for your patients. I was so mad and just totally dismissed anything they said after that. I became pretty depressed with all the nausea. I was barely holding down a job. I wasn't sleeping. I couldn't eat. From the perspective of specialists, I was holding down a job. So I was okay, but I felt awful. I did see a mental health therapist at that point. I did about 10 to 20 sessions. It helped me cope. But I did not feel better. I certainly didn't feel worse from that, but I was still nauseous all the time. I lived with that nausea for 8 years. I had one doctor who suggested to me, and I found this really helpful. They suggested to me to try a mild antidepressant, an SSRI, and that actually helps gut health. So I kind of perked up at that. And they said that they found, I don't remember exactly how they explained it. It was something about the way the serotonin works in your brain is similar to your gut, and that can help. I don't know. But I found that a much more inviting way to talk about mental health. And then I was open to say, oh, I have been kind of down about this, and was like, oh, I could take this medicine, it would help my gut, And so I still said, like, no, I don't want more medication. I'm already on so much. It's already super toxic. So I didn't pursue that. But it did plant a seed for me to wonder about the possibility. And so at that point, fast forward, it had been years since I saw a therapist. So I went again, because that's what you do when you're not dealing. And it wears you down. So I told her about the constant nausea, and she explained that sometimes an anxiety attack can present itself entirely in the body as nausea in the way I described. So the initial waves of nausea would be probably because of my illness or meds or eating something. The lingering and the intensity of it could actually be mental, in that it was my mind's like protective response, but I felt it all in my body. And so I was up to try anything. So I started medication and therapy for this. And when you feel bad enough, you try anything, right? So I would say about 3 years of that, I finally found the right concoction of medication, done a few different treatments of therapy, and I can say today that I no longer live with constant nausea, and I never thought that would be possible.
I'm really happy.
Thank you. Yeah. So I guess just really quick, like, there's so many barriers to accessing that support. And I had a lot of those. Like, it's really expensive. I was a recent college grad. I do not fit the stereotypical mold of a mental health patient. So I am pretty chill. People say I'm bubbly and cheerful. I got my master's degree during this time. I'm pretty successful, can do work. I'm in a helping profession. I help other people in their suffering. So I guess I would encourage any of you out there listening that even your physical symptoms can sometimes be triggered by mental health that you don't even know, and to get, to not be opposed to trying that road of accompanying treatment for your illness.
You know, I've over the years, I've come to think of it as a great gift that toxic people and situations literally make me sick. And I have such a clear signal from my body, that is not for me, that I am quicker to extricate myself from people or situations that don't feed and nurture and support. So it's not a consolation prize that I would wish, but I think of it as a gift, because it's so clear, and my body reacts like yours, so violently and vehemently to nonsense. Right, that it gives me, I've created that. I would say it gives me the freedom to just cut to the quick and to just put myself in situations that make sense, move forward, allow me to make my contribution, have it valued. So it's a good signal. But for doctors, Dr. Lammert, the question is, how can we convey all of this that's going on in our heads and in our bodies that's so subtle or silent, to you, so that you can help us? For the doctors who want to hear the signals, do receive them.
Yeah.
What have you learned?
Yeah, so Donna, I mean, it's an incredibly important point. And again, I think it starts with a receptive doctor. And I think, historically, we've really focused on patient-doctor relationships, but probably in the wrong context. Again, the kind of commonality is that we look at your labs, they look perfect, and I'm going to pat myself on my back because I'm doing an excellent job. And unfortunately, that's just the superficiality of patient-doctor relationships. And it's really good. We have to advocate for doctors to really take a deeper dive. And here is the challenge at hand. As a hepatologist, I'm not a mental health expert. I may not even be a gastroenterology expert as well. So your feelings of depression, poor sleep, your joint pain, either one, don't interest me, or two, I'm scared because I don't know about them, in all honesty. But I think it takes a doctor to lean into that. And I think we've lost this art in some regard to run from what we don't know. So I will challenge patients that are watching, that will ever watch this, that you're looking for a relationship, a working relationship. I think if you're going to the doctor to expect to know the answers, I think you're going to be probably unhappy. But again, if you find a doctor that's willing to work with you, to ask the dark and deep questions, to understand how you feel, I think that is the only type of relationship that will ultimately result in improvement in quality of life, because there is a big change on the horizon. I hope this continues. And this is one thing that our organization, the Autoimmune Hepatitis Association, wants to accomplish. We need to move beyond living forever. We all want to live forever. We all want to live without a liver transplant. But I think somewhat taking a spotlight off of that and sharing it with also quality of life. And I think we've gotten a lot of traction in other autoimmune diseases, particularly PSC and PBC, still probably not to the point that we need to be. But AIH is unfortunately very underrepresented in terms of studies and interventions, and presents a unique challenge to our patients. And again, one of the things is, as drug companies and experts and doctors say, well, AIH patients have dedicated treatment. And I'd say, well, so what? If the treatment causes problems, or if they have more issues beyond liver inflammation. So again, more targeted therapies and more of at least a care or an approach to extrahepatic symptoms of the things that we've been talking about is the only thing that will improve quality of life. eventually. So work with your doctor, find a relationship that will work for you. And again, don't be afraid to move on. Advocate for yourself. And again, if you get flags, there's a reason for that. But again, it should be a part of the care team, and it shouldn't just live within the liver office. It lives among your primary care doctor's office, your rheumatologist's office, your neurologist's office. And that communication is really at the centerpiece of those relationships. So
I have so many questions. This is great. So what are the current treatments for autoimmune hepatitis, just so people know?
So it's founded on corticosteroids like prednisone and budesonide in terms of initial response and treatment to get the immune system into shape very quickly. There are chronic immunosuppressants that we like to bridge beyond corticosteroids. These are things such as azathioprine and Cellcept and Prograf, cyclosporin, sirolimus. These medications are typically used lifelong. However, there are probably some patients that we can remove therapy after a few years if you look at the new ASLD guidelines. But there's still a lot to learn about that. But again, the big statement I will say is these therapies are, again, the hammer and the patient is the nail. We are broadly suppressing the immune system. And in fact, really no targeted therapy for AIH probably exists as of yet. And I think we'd like to get to an individualized approach, because I think one of the big questions is, does the medications cause some of the side effects and or symptoms, or do they exacerbate that? And I think that's a really important thing to understand going forward.
I know one question that I won't even pretend I'm like asking this for a friend. No. So one question that that I'm not alone in having is about tapering off of prednisone.
Yeah.
If you have been on it for a number of years. And the expectation seems to be, at least has been communicated to me, that it's this very linear process that you just this and then you cut it by 1 or a half over this week, and then you're off. Ta-da! And like, my body doesn't seem to be responding that way. It seems to sort of get stuck here. And then we're hoping that, like, we're making this as it's just gonna like come in and come alive and start to work and recognize they're like, oh, you want us now? Okay, yeah, we're gonna turn up that engine again. I'm not sure that it's there, and so reading more of the literature, some that exists, very little exists of okay, this amount of time on prednisone, it takes this amount of time to taper for this long. I don't think it's that straightforward, and I just would love your thoughts on how to.
Yeah, and maybe before I give those thoughts, maybe we should ask Katie what it's like to come down off of prednisone too, just to give her flavor.
Absolutely.
Yeah, I one time got off of prednisone for about a month, and then my disease triggered again. So, or my immune system. So I have actually never come off of prednisone, and I have had every doctor change I have tries to get me off of prednisone. So I have now tried this at least 10 times, probably. At some point you say it's just not happening. So I am on a kind of management dose of prednisone, the lowest possible dose. And we're always trying to play with what's the lowest possible dose I can stay on and feel good and live with. And that has been a hard hurdle of acceptance for me, of saying like, I'm just on this because I feel terrible as soon as I'm with you. I can't quite get over that little hump with my adrenal glands. They don't kick in. And
so maybe I can come in and say, you know what, prescriptive approaches to decreasing prednisone just don't exist and should not be done. And in fact, this idea that there is a cookbook for AIH withdrawal of prednisone, if I knew that, I'd probably be a lot more known. I think, this is the fun part for me. And again, it sounds a little bit weird for me to say that, but that is the true art of medicine. There are patients, I think, that probably will require a little bit of prednisone, meaning that the way that prednisone works to control the immune system in conjunction with another immunosuppressant ultimately results in some better quality of life. I have a number of patients that stay on anywhere from 1 to 10 milligrams of prednisone as an adjunct,
Mhm.
And this helps to control their joint pain. This helps to, again, make them feel better. They feel more rested, again, surprising in the setting of prednisone. But I think this is a conversation with patients. And in fact, there's some data now looking at large groups of patients on chronic corticosteroid therapy, even at very low doses.
Mhm.
And again, historically, we used to think that low-dose prednisone probably wasn't worth in terms of significant infection risk, but it probably is a modifier. And in fact, in terms of rheumatologic diseases, there was a paper published this year saying that risk of hospitalized infections, where people have to go into the hospital for infections, is higher in patients on doses even less than 5 milligrams of prednisone. So it is a risk-benefit equation.
Mhm.
And again, this gets back to that idea of quality of life. I still routinely use low doses of corticosteroids.
Mhm.
Again, patients like me a lot better that way. But ultimately, you have to remember, goal is still to get off corticosteroids, if at all possible. But again, not following a prescriptive algorithm. It just doesn't exist because everyone is so different.
I think that's so helpful and so refreshing to hear. I also wanted to point out that you did mention ASLD guidelines, and it's my understanding that there are brand shiny new guidelines from ASLD in autoimmune. So
Yeah, there is. And maybe we should just quickly say what's really that different. And again, I think they did great with the guidelines, but again, there's not a lot different. And I think that should be a very clear demarcation of, we are just not making tremendous strides in this disease. I think maybe a few pieces that are worth mentioning. The biggest one is the idea of co-occurrence of fatty liver disease with AIH patients. Now, this is probably also present in PSC and PBC as well. But the idea that if we have, and again, America and our ever increasing waistlines as a risk factor for fatty liver disease, it can happen concurrently with autoimmune hepatitis. And in fact, those patients, and actually some of the work we've done here at Indiana University, it seems that patients with NASH or fatty liver disease plus AIH are, one, harder to control in terms of liver inflammation. Two, they have more progressive fibrosis. And three, they end up doing worse and requiring more things such as liver transplant. So I think, this idea that we are unlucky to develop an autoimmune liver disease, well, you're not unlucky. You're lucky enough you can actually get another disease on top of that. So again, I think we have to, as doctors, but also patients, have to approach it that way. And in fact, there's other disease modifiable pieces as well that need to be considered during autoimmune in the realm of autoimmune hepatitis as well.
The key for me, the sort of breakthrough moment in my being able to really get optimal care was when I was finally persuasive in getting my team to view me through an autoimmune lens. That's about having UC or Crohn's disease or PSC or post-transplant, and just these individual cavalcade of conditions. It was about, I am an autoimmune patient that manifests in different ways. And so let's think, whole systems, whole body, whole person, the effects of whatever we're doing for one thing on the others. And I went to a rheumatologist who literally, I had to write a letter to the health system. And my ask simply was to get all of my specialists in the room at one time, in one place with me. And they grumbled, but it happened. And there were so many aha moments. They're sitting there with my labs and all things I've prepared on spreadsheets. And they're like, oh, we didn't realize that when we reduced the prograph that this, and but when you did that, they were pointing across the table that this did that. So finally the rheumatologist just sort of called the question, and he was like, she's going to go on a biologic.
Yeah.
And I did. And that, changed and my ability to function and changed everything for me. Yes, we've had to, make.
Yeah, so Donna, I think it's worthwhile to say that frame of reference is incredibly important.
Mm-hmm.
Again, any new complaint or symptom I hear in the hepatology office, I think that perspective will allow you not to miss things, hopefully. Right. And again, Katie may be able to speak to this too, but many of my patients have endocrinologists, have rheumatologists. Because again, I think it's probably bad to just dismiss the routine complaints we see in autoimmune hepatitis to just the autoimmune hepatitis. And in fact, one of the stats we love to share with people is 40 to 50% of patients with IH are going to have another autoimmune disease. Mm-hmm. The question is, has it developed yet, or is it indolent, or is it a variable presentation? In fact, something I've never quite understood is because we have patients on immunosuppression, why couldn't that be protective in the development of eventual rheumatoid arthritis or type 1 diabetes or whatever? So again, not unusual, but again, bringing in experts and trying to put together a team, and that teamwork is incredibly important. And maybe Katie can share her approach or her experience.
I'm going to give Katie the last word, in fact.
Wow. Okay. So I just want to say, Donna, like, I am super impressed at your ability to advocate for yourself. I think that our system, in learning it and working with teams of doctors, it takes a long time to learn that and be able to advocate at that level. And that is exhausting. When you feel that bad and you waited months to get in with a doctor and then you are dismissed, it is heartbreaking and it is exhausting. And so I would just say I have found the system it's not built that way. And even finding a really good primary care physician and developing a relationship with them, like, that's so important because they are the hub to connect all these doctors. And yet that system is broken. Your primary care physician sees hundreds of patients and you are not on their radar. And they are not talking to these other doctors regularly. And when you come in with new symptoms, they're most likely to say, what does your specialist say? And then your specialist, you go with a new symptom and they say, bring it to your primary care physician. So you get passed back and forth and back and forth and back and forth, and nobody takes you seriously. So to be able to get them in the room or talking to each other, you end up calling them again and again and again and again, and you don't get calls back and you don't get the lab work you need. And so you really are yelling into the void. So I don't know. I mean, we are talking about a whole system change and thousands of millions of dollars and the way our healthcare and health insurance is designed. And it is right now a mess. So I just applaud you for that work of self-advocacy. And I hope that, like, some of us can, like, continue on towards that goal. I am not there where you are. That is incredible.
I was not there where, either before I had to get here. But I'm going to share with you a few things. Literally, it's one sheet. Rather than saying, my doctors need to get on the same page. So, because they were telling me couldn't even decide on, like, the hemoglobin they could agree I could meet. So I literally put to, like, all my specialists and, like, tequila and then goals, like, just so, and I would shop it around to each of them, and I would hand it to, like, fill it out. Like, what is your goal for me? You want a hemoglobin? Like, hematology thought I could reach a hemoglobin of, like, 11. Gastroenterology's like, you'll never be an 11. I was like, well, why not? I'm like, well, let's have that conversation, because that's a productive conversation about where you think we should be going. Let's have that. And so, put it on one page. And
wow.
Then I lawyered them into the, but it was, creative buy-in and guided conversation. So come to our Advanced Advocacy Academy.
Yeah. Cool.
And yes.
Can you say that again? Come to.
So GLI has now created an Advanced Advocacy Academy. And so I'll teach you all my tricks. And we're in our 4th year now. And this is where you get the cool insider. So we can all live this long. Yeah.
So I would also just interject and give a plug similar to that. Like, I am totally in. Also, Dr. Lammert has been really in the forefront of developing the Autoimmune Hepatitis Association. And this has been huge for me. So there's, like, a conference every other year where I get to go and meet other patients with this rare disease and, like, learn more about the illness and join studies, which I never thought any of that would happen. And then they just started support groups. So I have, like, every couple months I go to a support group and talk to other patients. that kind of connection with other patients is huge. And to have a voice where doctors are listening to what's going on and want to hear, I just think like I would lift up Dr. Lammert as a model of that, of what a doctor could be, and also just invite you to join the AIHA if you have autoimmune hepatitis. It's really cool.
Thank you. And one of our staffers has been working with both of our organizations. And so that's exactly what we want to foster. So Nicole Wells, who runs our Pediatric and Rare Liver Disease Council now, is an A3 or graduate. And, you know, when she asked me, so can I still work with the autoimmune? I was like, yes, absolutely. We're about collaboration and lifting each other up. And I have such a huge respect for what Dr. Lammert has built with his patients. And I mean with, and that whole approach that, yes, I look forward to, you know, this conversation and the work, you know, with Nicole being the bridge as just being, you know, the start of our collaboration. And I think that's a, you know, that's the real point to end on, that, you know, this day as GLI launches its Pediatric and Rare Liver Diseases Council, we wanted to give this platform to your organization, Katie, to your voice, Dr. Lammert, to your work, as just the beginning of our work together. So thank you.
Yeah, that's great. And I'll finalize that by saying it is a two-way street, Donna, from the clinician to the patient, but also in the advocacy community.
Mm-hmm.
I've learned more from patients than I've probably ever learned from textbook or publications. And I think it's just, it takes doctors and patients being receptive to symptoms, outcomes, strategies, treatment. As we learn more about these diseases, we need to continue to come together in that form, not only in terms of advocacy, but education and research. And in fact, research should not be limited by geographic constraints. And in fact, it's something we've done really well with the AIHA. And in fact, you can participate in our genetic studies from the comfort of your own home. So again, we must continue to advance into the beyond 2020. Mm-hmm. But the very final thing I'll say is autoimmune patients are not alone. And I think that's important to say. This time of COVID-19 is incredibly important. And again, this is unprecedented. And in fact, we are seeing a peak in a lot of symptoms in the patients with chronic illness. You are not alone. But again, I would say continue to talk and advocate to your doctors, ask for help when you need it, but also lean on the loved ones in your family as well. I think, again, we're going to see a lot of fallout in the next few years from this time in our lives. I just don't want AIH patients or any autoimmune liver patients for that matter to end up worse for the wear because of it. So pay attention to your body, and now is just as good a time as ever.
Amen. Thank you. And thank you to everybody who's been watching and listening. And you can find more information about the Autoimmune Hepatitis Association, about several of the things that we've mentioned here, including the Advanced Advocacy Academy. We'll put them in links. You can find them on globalliver.org. And until next time, where we'll be talking about thriving and surviving post-transplant with some of my fellow transplant recipients and other favorite people. So thank you. Stay well, stay safe, be connected, and a happy Thanksgiving. Happy, safe Thanksgiving. Bye, everyone.
Thanks, Donna.
Thanks.